Hello, and thank you for joining the Ambulatory Specialty Model Participant Office Hour. Next slide, please. We recommend listening via your computer audio. If you prefer phone audio, dial-in options are available. Closed captioning is also available by selecting it at the bottom of the screen. Please also complete the short survey at the end of this webcast. This will help us inform the development of future ASM training and technical assistance materials. Next slide, please. Today's session will provide a brief overview of ASM, key details about the mandatory model, and next steps for participants. After a brief presentation, the ASM Model Team will be available to answer both pre-submitted and live questions. The content of this presentation was informed by questions received via the ASM Help Desk and questions submitted during the registration for this event. We will share links to key ASM resources at the end of the presentation, and following this event, presentation materials will be available on the ASM website. Please submit your questions via the Q&A box. We'll answer as many questions as time allows. If you have multiple questions, please submit them one at a time so our team can get to as many of your questions as possible. If we don't get to your question, or if you have additional questions, email us at ambulatoryspecialtymodel@cms.hhs.gov. The ASM Model Team answers questions submitted to the ASM Help Desk directly, and the ASM email address will also be included at the end of this presentation. We'll use this office hour to respond to general questions relevant to most participants. So for ASM questions that are specific to your situation, please email us at ambulatoryspecialtymodel@cms.hhs.gov. Next slide, please. My name is Ben Vicillo, and I am the ASM Model Lead with the Center for Medicare and Medicaid Innovation. I am joined by ASM Model Team members Mitchell Beers, Coleman Adams, Molly Gilbert, Aria Gray, and Genevieve Kehoe, who are all available to answer your questions. And you'll see many of them in a bit in this presentation. Next slide, please. To kick off today's presentation, I'm going to first provide an overview of ASM. At a high level, ASM responds to a common challenge in original Medicare. Many patients with chronic conditions see multiple clinicians and care can become fragmented. This fragmentation leads to challenges in care coordination across providers and care settings, leading to treatment delays, unnecessary procedures and hospitalizations, and ultimately worse health for patients. To respond to these challenges and to bring more specialists into value-based care, CMS created ASM. ASM will test whether performance-based payment adjustments for specialists paid under original Medicare can improve care for patients with common chronic conditions, specifically heart failure or low back pain. ASM is a mandatory model, meaning that selected eligible participants must participate and do not have an option to leave the model. As a mandatory model, we established ASM through the calendar year 2026 Physician Fee Schedule, final rule, the Physician Fee Schedule, also commonly referred to as PFS, and all of ASM's regulations and requirements are described in that rule. ASM will begin on January 1st, 2027 and run for 5 performance years through the end of 2031. ASM participants include individual physician specialists that treat a high volume of patients with heart failure and low back pain, and ASM beneficiaries are considered any original Medicare beneficiary with heart failure or low back pain who receives care from an ASM participant. Next slide, please. ASM participants are individual physicians. This differs from other innovation center models that often identify a practice or a site of care, such as a hospital, as a model participant. Accordingly, ASM participants are identified based on a combination of taxpayer identification number, also known as TIN, and a national provider identifier, or NPI. So we refer to that combination as the TIN-NPI combination. The ASM participant eligibility criteria were designed to identify specialists who treat a higher volume of original Medicare beneficiaries with ASM's chronic conditions of focus. ASM participant eligibility is determined annually, and physicians will be evaluated for ASM participant eligibility criteria using data from 2 years before the start of a given ASM performance year. So, for example, our final determinations and for the ASM participants for the 2027 performance year will use data from calendar year 2025. As I mentioned before, physicians are selected as ASM participants if their TIN-NPI combination meets all of the following criteria for a performance year, and I'll walk through each of those criteria. So for billing, a clinician must bill claims under the Medicare Physician Fee Schedule. For specialty type, a clinician must have one of the selected specialty types for one of the ASM cohorts. So for heart failure, that includes physicians with a specialty of cardiology, and for the low back pain cohort, that means physicians with specialties of anesthesiology, interventional pain management, neurosurgery, orthopedic surgery, pain management, or physical medicine and rehabilitation. For episode volume, a clinician must have 20 or more attributed episode-based cost measures, or EBCMs, episodes from either the heart failure EBCM or the low back pain EBCM. And finally, for service location and geography, the clinician must practice in an ASM-selected mandatory geographic area, which are core-based statistical areas, also known as CBSAs or metropolitan divisions. While rare, if a physician's NPI is associated with multiple TINs, it is possible for a physician to be selected as an ASM participant under more than one TIN NPI combination. In that situation, each TIN NPI combination is considered a separate ASM participant. That means that the physician would be required to separately meet model requirements and report data for each TIN NPI combination, and performance assessments and payment adjustments will be determined separately for each of those TIN NPI combinations. Next slide, please. As noted on the previous slide, the EBCM data used to determine ASM participant eligibility is based on data from 2 calendar years prior to the applicable performance year. So to repeat the example I gave earlier, the final list of participants for the 2027 performance year will be identified using calendar year 2025 data. And similarly, for the 2028 performance year, we'll use calendar year 2026 data, and so on and so forth. Physicians must have 20 or more attributed episodes from either the heart failure EBCM or the low back pain EBCM to meet that eligibility criteria. We've received several questions about EBCMs and their attribution, so we recommend reviewing CMS Quality Payment Programs or the QPP cost measure website for detailed EBCM information, including how episodes are attributed to a clinician. Specialty type is determined by identifying the most common specialty type included on a physician's Medicare Part B claims in the year of data that we use to assess eligibility. Claims-based specialty types are assigned by MACs during claims processing and ultimately use clinician-reported information on specialty type that clinicians provide during Medicare enrollment, often through the PACO system. Next slide, please. ASM will be implemented in selected regions throughout the country, specifically core-based statistical areas and metropolitan divisions, which are geographic regions defined by the federal government for the purpose of collecting statistics. We selected these mandatory geographic areas by using a stratified random sampling procedure in accordance with ASM's regulations. Selected geographic areas are available on the ASM website under the Participant Information tab. We use the service location zip codes reported on fee-for-service claims used to construct episode-based cost measure episodes to determine whether a physician practices in one of ASM's selected mandatory geographic areas. So I'll walk through this process at a high level. First, we assign each EBCM episode a service location zip code based on the claims that are used to construct that episode. Second, we map that zip code to a single CBSA or metropolitan division. Finally, we determine the participant service location based on the most common CBSA or metropolitan division across all of their attributed episodes. Please note that the service location that CMS determines for an ASM participant may differ from the organization state, which is a state listed on the public ASM participant data set. For most ASM participants, the organization state listed does match the state of their service location, but we have been notified of some situations where that has differed, and we're looking into that in the publication of the final list. I also want to touch on a few situations that may affect whether a participant must meet ASM's requirement for a given performance year. If an ASM participant reassigns billing rates to a new TIN during an ASM performance year, they must notify us within 30 days of that change. After this has been acknowledged by CMS, the participant would not be required to meet ASM's requirements for that performance year. They will be subject to any applicable MIPS reporting requirements if they're eligible for MIPS for that same performance year, and they will also not be subject to any additional waivers that are provided under ASM. Additionally, if you join a new TIN, let's call it TIN A, but remain in a different TIN B in which you were also identified as an ASM participant, you would still be considered an ASM participant for TIN B for that same performance year. Please also note that a mid-performance year location change within the same TIN or specialty type changes, do not affect ASM participation during the current performance year. Changes may be reflected in future claims data and thereby eligibility for future performance years. Next slide, please. We released a preliminary ASM participant list for 2027 in February 2026. That preliminary list was based on calendar year 2024 data, and you can view that participant list on data.cms.gov. We plan to reassess the preliminary participant list in late summer of 2026 using updated calendar year 2025 data to confirm continued eligibility. We do not expect that any new participants will be added to that preliminary list, but there may be some participants that are excluded due to changes such as changes in service location, specialty type, or the volume of services as measured by EBCM episodes. We just want to thank everyone who has emailed us and the ASM help desk specifically to notify us of organizational changes that are not reflected in the preliminary participant list. We are noting down reports of these changes and including the specific circumstances as we receive them. Most of the organizational changes will be reflected in the final 2027 participant list after that list is reassessed using refreshed data. We also plan to conduct further checks for organizational changes, retirements, and Medicare enrolled provider status prior to the release of the final 2027 list. Once that final list is released, we will share further guidance on the notification process for organizational changes that are not reflected in that final list. We just also want to note that we do not plan to update the preliminary participant list posted on data.cms.gov based on organizational changes that are reported to us before we release the final list. So we will replace that list with the final participant list once available. Next slide, please. We've received many questions about ASMs promoting interoperability or PI performance category. So I'm going to spend a few minutes just going over these requirements and highlighting some of the common questions. To receive a score greater than 0 for the PI performance category, an ASM participant must, 1, attest to using Certified Electronic Health Record Technology or CERT during a performance year. 2, they must also fulfill all PI measures objectives. And 3, that the data submission also must be reported at a group, or that's the TIN level. And we also note that this data may include data reflected of clinicians not in ASM. And that's to also reduce burden and also to allow data that's being used potentially for MIPS PI purposes to be used in ASM. Failure to meet PI requirements will result in a negative 10-point adjustment to the final score. Unlike MIPS, ASM does not offer automatic PI reweighting or PI-specific hardship applications. We recognize solo practitioners and small practices may face additional challenges with these requirements, and we've accounted for this through ASM scoring policies. Specifically, ASM participants who are solo practitioners will receive an additional 15 points on their overall final score, and ASM participants in small practices will receive an additional 10 points on their final score. As we've noted previously, these scoring adjustments are to replace reweighting policies that were otherwise available under MIPS. We plan to release data submission guidance during ASM's first performance year. More details are also available in ASM's regulations and in the 2026 PFS final rule. We also recommend reviewing the ASM overview webcast, which is currently posted on the ASM website if you'd like more information on the PI requirements. Next slide, please. We've also received several questions about the improvement activities performance category. ASM's improvement activities category includes 2 required IAs. ASM participants must attest to completing must attest to completing both of the 2 required IAs. And these IA attestations are reported at the group level, or that's the TIN level, which means that attestation states that all ASM participants within a TIN must adhere to the IA requirements to attest affirmatively. IA1 is focused on primary care connections and health-related social needs screening. Participants attesting affirmatively must have workflows or processes in place to ensure that 1, every ASM beneficiary has a primary care provider, 2, that they are sharing relevant information back to the primary care provider following a visit with an ASM beneficiary, and 3, they confirm beneficiaries have received a health-related social needs screening. This screening is likely best conducted by the primary care provider, with the ASM participant confirming that it has been completed. But the ASM participant may also choose to complete the health-related social needs screenings themselves. IA2 is focused on establishing communication and collaboration expectations using collaborative care arrangements, or CCAs. IA2 requires that at least one CCA occurs with a primary care practice. These CCAs must include at least 3 of the 5 collaborative efforts of focus, which are data sharing, co-management, transitions in care, closed-loop communications, and care coordination integration. These are intentionally broad and overlapping to allow flexibility in CCA efforts. Both IAs and their associated activities must be in place for at least 90 consecutive days during a performance year. We may audit attestations, and ASM participants must retain documentation showing that IAs were implemented and maintained, such as documentation on workflows, EHR screenshots, meeting notes, and other operational materials. Completing only one IA results in a negative 10-point adjustment to an ASM's participant final score, and completing none of the IAs results in a negative 20-point adjustment to the final score. If both IAs are completed, no final score adjustment is made. Additional resources for ASM's improvement activities requirements will be released during 2026 prior to model launch. Next slide, please. All required ASM data will be due on March 31st of the year following the performance year. So first, ASM participants will complete a full calendar year of performance. So for example, January 1, 2027 through December 31st, 2027. During that performance year, participants are conducting required activities and tracking measures. And after that performance year is over, participants submit required data by March 31st following the end of that performance year. So for the 2027 performance year, all data submissions would be required on March 31st, 2028. ASM participants are required to submit data on the required measurements and activities for the quality, improvement activities, and PI ASM performance categories. ASM cost measures, as well as administrative claims-based quality measures, are calculated by us using claims data, so participants are not required to report any data. ASM data will be submitted through the QPP portal following a similar process as MIPS. Detailed information on required measures and other performance category reporting requirements is available in ASM's regulations, the 2026 PSF final rule, and in the ASM overview webcast available on the ASM website. We also plan to release further guidance on data submission during the first ASM performance year. Next slide, please. Our team has received many questions about how ASM will overlap with other Innovation Center models and initiatives. ASM was designed to freely overlap with other models and initiatives. This means that specialists can participate in ASM while also participating in an accountable care organization, an ACO, the Medicare Shared Savings Program, as well as other Medicare initiatives, and they'll remain eligible to receive incentives under these programs and models. ASM participants can also continue to participate in other Innovation Center models. Further, if participants are considered a qualifying participant or QP in an advanced APM that is not ASM, they will remain eligible to receive the QP PFS conversion factor. Finally, while participants are in ASM, they are exempt from MIPS reporting requirements. ASM uses a similar performance measurement structure as MIPS, so measures and scoring may feel familiar to many prior MIPS eligible clinicians, but ASM has different participation requirements and payment adjustment methodologies. And so ASM, is, as we've said before, is a mandatory Innovation Center alternative payment model and is not traditional MIPS or MVPs. The ASM Model Team is working directly with the Quality Payment Program to adjust MIPS eligibility determinations because of required participation in ASM starting in 2027. Next slide, please. To prepare for ASM launch on January 1st, 2027, physicians should confirm whether they have been selected as a preliminary participant by reviewing the ASM participants dataset, which we've linked on the slide. Once they've confirmed that they're a preliminary participant, we ask that they complete the ASM participant contact information form so that they continue to receive timely updates for model deadlines and resources. Preliminary participants should reconfirm their final selection when the final 2027 participant dataset is released, which we expect to be in late summer 2026. In parallel, participants should also monitor email, including spam or junk folders, for additional updates and emails from Ambulatory Specialty Model at cms.hhs.gov. We also note that an ASM participant readiness roadmap is available to guide you through readiness activities you'll need to complete before the model launch, and that's available on our website. Next slide, please. When notification emails were sent to ASM participants about the preliminary list in February, some participants received emails noting that the email address that we have on file for them is the same as other ASM participants. Our team also sent out a reminder email to complete the form in mid-March. If you received that reminder email but completed the form, it's likely that the initial form submission continued to include duplicate email addresses. So we ask that you take a look at that form and resubmit that as well. We also know that there were some situations where participants did not receive emails, and we were working to gather as many unique participant emails as possible. If you are an ASM participant that received an email asking for a unique email address, please complete the contact information form, and my colleague will also be sharing that sharing that link in the chat. We're asking for unique email addresses because they are required for ASM participant portal registration. We will provide further guidance later this year once ASM participants can register for the participant portal. ASM participants will be able to add additional context, such as a practice administrator, to their portals once the portal is open for registration. Failure to provide a unique email address for each participant will delay model registration and will limit ability to receive critical information through the portal. This will also restrict access to essential guidance and technical assistance needed to prepare for model launch. We understand the added work, but the need for a unique email address should only be to create portal accounts for all participants. After those portals accounts are created, multiple participants should be able to include the same contact on their accounts to receive updates, submit data, and conduct other administrative functions for the model. For example, once you register for the portal, a participant should be able to add an administrative contact to their profile that would be shared across multiple participants within the same organization. Next slide, please. So that concludes the presentation that we wanted to share with you, highlighting a lot of the common questions that we've been receiving and also highlighting some of the key model policies. So we're going to move into a Q&A portion of the office hour. So we really appreciate everyone for submitting questions when you registered, as well as submitting questions to the Q&A box throughout the presentation. So please continue to submit your questions. Just a couple of reminders. If you have multiple questions, please submit them one at a time so our team can get to them, to get as many of them as possible. And also, if you have specific questions related to your specific situation, please email us at ambulatoryspecialtymodel@cms.hhs.gov, because we won't be able to talk through all of those situations during this office hour. My ASM Model Team colleagues I introduced to you at the beginning of the presentation will also be joining me to answer your questions. So we're going to start first by answering some of the pre-submitted questions, and next we'll move into answering questions that have been submitted during the event. So I'm first going to turn it over to my colleague, Aria Gray, who's going to answer some questions related to participation. So over to you, Aria.
Thank you, Ben. Again, thank you so much for submitting your questions when you registered for this event and for continuing to submit questions during this event. As Ben mentioned, I'm going to go through questions related to participation. So the first question we received is, will this project be mandatory for any other providers than those already listed? So as noted during the presentation, CMS plans to reassess the preliminary participant list using calendar year 2025 data to confirm continued eligibility. As Ben mentioned, we plan to release that in late summer 2026. We do not anticipate that new participants will be added to this final participant list, but some may be excluded due to a change in service location, specialty type, or other circumstance, such as a volume of services. A note for future performance years is that ASM participant eligibility will be assessed annually, and clinicians will be evaluated for ASM participant eligibility criteria using data from 2 years before the start of a given ASM performance year. Changes in service during the years we use to evaluate the ASM participant eligibility could lead to a physician becoming a participant in a future performance year. And I'm going to move into our next question, which is, what should we do if a physician identified as an ASM participant left our organization? So as I just mentioned, CMS is going to reassess that preliminary participant list in summer 2026 using 2025 data to confirm continued eligibility. These changes in organizational affiliation may be reflected in that final 2027 performance year participant list. We will release further guidance on the notification process for any organizational changes not reflected in the final performance year participant list once that list is released. And given our plans to reassess reassess the preliminary participant list using 2025 data, please wait until the final participant list has been released. As I mentioned, the changes that you see may be reflected in that list, and then once that list is out, you will be able to notify us of anything not reflected there. Next question. An ASM, well, that was the answer. What if the participant does not anticipate completing the program? For example, retirement prior to completion. So an ASM participant who plans to retire before the ASM model ends in 2031 is still required to participate in ASM if they meet the model's eligibility criteria and remain a Medicare enrolled physician. As mentioned, ASM eligibility will be assessed annually using data from 2 years prior. If a clinician retires, that change may be reflected in a future year's eligibility determination. And we will, as I mentioned, and we will continue to release guidance on this. We will be releasing additional guidance on the notification process for organizational changes, which include retirements in the coming months. And I believe this is the last one from me for now, and it is, how can administrators receive information for all of their providers? As mentioned during the presentation, once ASM participants can register for the participant portal, ASM participants will be able to add additional context to the portal once that portal is available. Again, that's anticipated in late summer 2026, around the time the final participant list is released. Currently, we do not have a dedicated listserv for ASM, and an ASM listserv is definitely being considered and may be developed in the coming months prior to model launch. For now, we recommend checking the ASM website regularly for the latest information and updates, and you can always email us at our email address on the screen. And now I will turn it back to Ben.
Thanks, Aria. I'm now going to turn it over to Mitchell Beers, who's going to answer some of the pre-submitted questions around quality measures.
Yeah, hi all. I'm going to be answering a couple of questions about quality measures and other details. So one question we have is, what are the quality measures and reporting methods? What is the scoring methodology? And how will ASM payments compare to current payments? So a lot there, great questions. And rather than dive into those broad topics right now, we recommend viewing the ASM overview webcast recording and slides, which were recently posted on the ASM website under the participant information section of the website. This webcast provides an overview of the model's performance requirements and payment methodology, so you'll get all the information that you need there. A link to the recording and the slides and other ASM resources will be shared at the end of this office hour. We recommend reviewing ASM's regulations for more detailed information and anticipate expanding available resources before model launch in 2027. The next question that I have is, we have heard that MIPS Q220 functional status change for patients with low back impairments will not be supported in 2027. Will another measure replace this one? Thank you for this question. The ASM team is aware of this, and we are currently assessing next steps. We will share more information when we are able, which is as soon as possible. I'll pass back to you now, Ben. Thanks.
Great. Thanks, Mitchell. I'm now going to turn it over to Molly, who's going to answer some questions about collaborative care arrangements.
Thank you, Ben. As Ben mentioned, I will answer 2 questions on collaborative care arrangements, or CCAs. So the first is there a sample or model CCA that's available? Currently, we do not have a CCA template available, but additional resources, including for CCAs, may be posted on the ASM website in the coming months as part of future guidance. And then the next question on CCAs is, does an ASM participant have to have a CCA with every patient's primary care provider? And the answer to that is that ASM participants are required to have a signed written CCA with at least one primary care practice that they share an ASM beneficiary with. Ideally, they would share multiple ASM beneficiaries with the primary care practice that they enter into a CCA with to maximize the impact of collaboration, but only one is required. I'll hand things back to you, Ben. Thank you.
Thanks, Molly. I'm gonna turn it over to Coleman Adams, who will address some questions about payment.
Thanks, Ben. One quick question on payment. The question is, will the payment reduction or increase affect my heart failure claims only or all claims for that specific NPI? So ASM's payment methodology converts each participant's final score into a payment adjustment that will adjust all of that participant's Part B covered service claims for the corresponding ASM payment year. So for example, the final score earned in the 2027 performance year will determine the payment adjustment applied to 2029 Part B covered services claims. So a couple key points there. Each ASM participant, and that's TIN NPI as we've been talking about, receives their final score for the performance year. That score is then used to calculate a payment adjustment applied to that clinician or that TIN NPI's future Part B covered services claims under. And then each participant receives their own performance details and payment adjustment. We're not blending a TIN level factor or payment adjustment across multiple TIN NPIs. We intend to treat ASM payment adjustments similarly to MIPS payment adjustments in the shared savings program benchmarking calculations, as we've discussed in the CY 2026 PFS final rule. Back to you, Ben.
Thanks, Coleman. I'm going to cover a few questions that we received about MIPS reporting, waivers, as well as rulemaking. So first, will ASM participants need to submit MIPS and ASM together? And sort of relatedly, will ASM required participant data be included or reported for the group that they are part of it, or will it be excluded? So as I mentioned earlier, ASM participants are exempt from MIPS reporting requirements during the ASM performance years in which they're required to meet model obligations. So if you meet the criteria, those 4 criteria we talked about for 2027, you are not required to meet MIPS reporting obligations under most scenarios. So as a result, you would not participate in MIPS and you would not receive a payment adjustments for those ASM performance years. We are working with the quality payment program team to eventually adjust eligibility determinations if you are selected as a final ASM participant for 2027 and then for each year thereafter. We're also working with the quality payment program to answer this question about MIPS group reporting if there are ASM participants within a practice that is reporting as a group under MIPS. We're expecting that ASM participant data would not need to be excluded from that MIPS reported data as long as all of the data submissions aligns with MIPS eligibility requirements as well as data submission requirements as well. But we'll provide further guidance on that in the future. Another question we have is about, is there a small practice waiver or are there exclusions if this is, further requirements into taxing for small practices? So we do recognize that solo practices and small practices have specific challenges that make it more difficult for them to perform well in ASM without additional support. So as a result of this, we include scoring adjustments for participants who are in solo or small practices. So if you're in a small practice of 2 to 15 clinicians, that's any clinicians. It's not just based on the number of ASM participants within the practice. Those participants would receive additional 10 points on their final score, and solo practitioners, who are ASM participants, would receive an additional 15 points. Additionally, small practices can also report required quality measures at the group level, so that's a 10 level as well. So there's no available exclusions or waivers by virtue of being a small practice, which, as you could infer from earlier, we mean 15 or fewer clinicians. So ASM is mandatory model and physicians will be required to participate if they meet all of the eligibility criteria. We also want to flag that we also include a positive scoring adjustment for ASM participants who have a high degree of medically or socially complex patients, which we call the complex patient scoring adjustment. So you can earn up to additional 10 bonus points on your final score for treating patients with higher medical and social risk. And this is very similar to the complex patient scoring bonus under MIPS. And the last pre-submitted question I'll cover is when will the final rule be published? So the 2026 PFS final rule was published last year on October 31st, 2025. That's obviously already available publicly. There's more information on our website about accessing that rule. Rulemaking for the 2027 PFS, which would enact policies for the calendar year 2027, we expect would align with previous rulemaking schedules for that rule. So we would expect that the PFS, which typically comes out, would be final. The final rule would come out in late October, but that's subject to change as well. Now I think we're going to turn over to some of the questions we've gotten as part of today's office hour. So I'm going to cover a couple, which I think just reiterate a couple points. I think there's one question about if you're a participant identified under 10A and you stay in 10A, but then you also start reassigning billing rights to 10B, would your ASM participant status move over to 10B as well? Currently, no. You would only be considered that the participant under 10A, and you would not be required to participate under 10B. In the future, if you remained under 10B, you could potentially be added as a new participant in future ASM performance years. I think there was another question on that point of like, will there be additional ASM participants added over the 5 performance years? Yes. So it is possible that participants could be added in future years. And then one last point, there was a question about whether or not TINs could be provided on the ASM participant dataset on data.cms.gov. We unfortunately cannot provide TINs on public sites, as that's a piece of PII. So we're not able to share that now. But if you do have questions about that dataset, please feel free to contact us at Ambulatory Specialty Model at cms.hhs.gov. All right. I think I'm going to turn it over to Mitchell to answer some of the questions that we've gotten around some of our measurement framework as well as our performance category requirements. So over to you, Mitchell.
Thanks, Ben. Yeah, I'm gonna just answer a few here that have come in. So one that came through early on in the webinar is, even though ASM is built on MIPS MVP framework, it's a CMMI model. Will data be submitted through QPP similar to MIPS? If not, how and what will file requirements be? I think Ben answered part of this in his presentation, so that will probably be more clear from the presentation slides. But CMS is intentionally aligning operations where possible to reduce burden. Data submission for ASM will leverage the existing quality payment program infrastructure, including the QPP portal, and familiar submission methods. In terms of file requirements, submissions will generally mirror MIPS formats and workflows, but they'll be specific to ASM's required measures and categories. So that's a quick response on that one. Another question that came through is, will participants be able to submit their quality IA and PI data through a CMS qualified registry? And the answer to that is yes. Participants will be able to use CMS qualified registries. ASM allows data submission through third-party intermediaries consistent with MIPS, which includes qualified registries and QCDRs. This is intentional to leverage existing reporting infrastructure and reduce burden. There was another question that came in that said, I have groups of 75 providers and 5 providers are eligible for ASM. The rest are eligible for MIPS. For IAs, why do all 75 have to report these new IAs rather than just the 5 who are ASM eligible? So that is a great question. And the answer to it is that the ASM IAs actually only apply to the ASM participants. So while the IA category is reported at the TIN level, this does not mean that all providers in the TIN must adhere to the ASM IA requirements. IAs only need to be reported for the ASM participants in that TIN. If all ASM participants in the TIN are meeting the ASM IA requirements for their ASM beneficiaries, then they're meeting the expectations of that IA. So that was a lot of detail. The webcast recording that we have on the ASM website dives into that in a little bit more detail if you want to review those slides or the recording. And then I'll do one more now. Providers who remain in ACOs, are they reporting on the ACO quality measures as well as the new ASM measures? And yes, providers in ACOs may still have ACO reporting responsibilities, and ASM does not replace those requirements. So I will pause there and pass it back to Ben to usher in some more questions.
Great. Thanks, Mitchell. I'm going to turn it over to Coleman. I think he's going to cover a couple of the questions as well.
Sure. And thanks all for the questions. The first question that I'll be answering is what exactly makes an encounter an episode-based cost measure episode? And so I think this is a question around how do we assign episode-based cost measures to participants? And each episode-based cost measure has its own alignment or attribution methodology that uses a series of triggering and re-triggering claims within designated clinically relevant timeframes. So those are dependent on the heart failure or the low back pain episode sets. And so those triggering and re-triggering claims or codes are then used to assign attribution for specific beneficiary, assigning a beneficiary towards a specific participant. If you would like to see a full set of sort of those triggering and re-triggering codes, those are on the QPP website, or you can email us at the email address on screen, and we can flow that along to you. The second question is, if a participant does not submit data, what would the penalties be? And so I believe this is asking around our minimum quality data submission requirements. Those quality data submission requirements are a bit nuanced, so I would point you to the rule to see exactly how and when you meet those requirements. But if you do not meet those requirements, the penalty would be you would receive a final score of 0, and that would carry a consequenting a sort of a payment adjustment reflective of that final score. The last question I'll answer right now is, how do you evaluate a participant as a small practice or solo practice? This is determined on the TIN size that you're participating with. So if you're an NPI that has 15 or less NPIs participating with that TIN that you're under, you would receive the small practice score scoring adjustment. If you're the only NPI under a TIN, you would receive the solo. So it's based off of the TIN that you're participating in with ASM and the amount of NPIs associated with that TIN. It's all for me right now. Let me see what else I can get to.
Thanks, Coleman. Yeah, and keep the questions coming. Really appreciate all these. These are great questions. I will just add one so a clarifying point on the payment methodology. So the question is, if they're one of many providers in the TIN is selected as an ASM participant, is the revenue of all providers in the TIN adjusted based on performance? No, it is only the NPI's payments would be adjusted based on ASM payment adjustments. So if you have two of your providers or participants within your practice, those are the only their payments would be affected by ASM payment adjustments. I'm also going to ask a couple questions about that I've seen about sort of the intersection between MIPS, MVPs, as well as with the shared savings program. ASM participants are not required to register for the MVP. Again, ASM is not MIPS. It's a whole separate reporting structure, even though it has a similar framework. So again, not required to register for the MVP. Some questions related to the shared savings program around whether or not participants within the shared savings program need to report MIPS. There are no exemptions from ASM requirements by virtue of being in the shared savings program. So that includes you still, if you're selected as an ASM participant, you still need to meet all of ASM participation requirements. That also includes the promoting interoperability requirements as well, and report data on those. I'm just looking through our questions. Aria, maybe I'll turn it over to you to answer a couple more questions.
Yes, thank you, Ben. I have a few more participation contact information questions. The question is, and my screen more questions are coming in, and my question keeps running away from me. The providers that we identified are employed by our hospital organization. Is it possible to complete the ASM participant contact information form with multiple individual contacts or designate a single contact at the organizational level to represent employed providers? The easy answer is that will eventually be possible once the ASM participant portal registration is complete. The participant portal is not available right now. As we mentioned during the presentation, we do anticipate that the portal will be available late summer 2026 at the same time the final participant list is available. For now, the contact information form, any email addresses submitted through that are not replacing email addresses in other administrative systems like Paycos. We are just receiving them on our end. As we mentioned, participants in this model are individual physicians and not hospital systems or organizations. So we are working very hard with our systems folks on the back end because this means we have to configure our systems slightly differently than previous models. And that does require unique email addresses for all participants. So really, this is just for the participant portal registration. And once registration is complete, participants can have the same contact. And that is why we are also considering and working on getting an ASM listserv created so that we know that communication and hearing all the updates is key. So that those are things that we are working on. Something that we have seen from some groups submitting the form is they're creating ASM specific email addresses for their participants. So, first name, last name, asm@emailaddress.com, which I think could be managed by a singular individual. However, we know that is not possible for all of our participants. The last question that I have for now is, can you confirm that we only have to participate if our organization is on the list? That is correct. Right now, the only participants for ASM are the individual physicians listed on the ASM participants dataset on data.cms.gov. And as mentioned, once we reassess the 2025 data, we do not expect new participants to be added to the 2027 list. That's it from me for now, Ben, and I'll pass it back to you.
Great. Thanks, Aria. Checking. Just invite Genevieve. It looks like you have a few questions. So do you wouldn't mind covering those?
Yeah, sure. So there was one question, can we opt out of the model? In short, no. Physicians cannot opt out of ASM if you are selected. ASM is a mandatory model, so physicians who meet the eligibility criteria and are included in the final participant list are required to participate for that performance year. A physician may be excluded if they no longer meet eligibility criteria like change in specialty type, lower volume, move service locations, or some otherwise excluded by CMS during that annual reassessment. The second question, will the chosen CBSAs change over the 5 performance years? No, the CBSA selected will remain the same over the course of the model performance period. Okay, Ben, back to you.
Thanks, Genevieve. I'm going to answer a few questions. So one is about, will ASM participants be informed of their attributed beneficiaries during the performance year? So we do intend to provide data that would provide historical information on EBCM episodes, including the attributed beneficiaries, as well as looking to provide data around excuse me, sorry, I had a computer problem. Include data on those beneficiaries that meet the definition of an ASM beneficiary. So we do anticipate answering that. And I am going to turn it over to, I think, Molly, you had a question to answer.
Hi, thank you, Ben. We had a few questions about when a practice has physicians or clinicians who are listed as not being in ASM and some physicians who are listed as being an ASM and how that impacts MIPS reporting for clinicians who are not listed as ASM participants. So those clinicians would need to report for MIPS if they are listed as eligible clinicians in MIPS, or rather if they are eligible for that program. And so that they would have to do MIPS if eligible. Thank you.
Great. Thanks, Molly. I'm going to turn it back over to Mitchell. Looks like we have some questions about performance category requirements and reporting.
Yeah, thanks, Ben. So we have a couple questions that are related. One is, when will we get specific information regarding improvement activities, PI activities requirements? When can we plan on beginning to incorporate these workflows in advance of 2027? And then another question, further guidance. We stated that further guidance on data submission will be released during 2027. How would you recommend we begin to collect data in advance and during 2027? And what are the specific details? So the answer is that CMS has finalized the core requirements in the calendar year 2026 physician fee schedule final rule of ASM. So you can reference that final rule for a lot of these details around what is required, as well as the resources we've mentioned that currently exist on the ASM website. Both of those are the primary tools that you should use to understand the performance categories, the requirements therein, and how to start working with workflows. And we intend to continue to add resources in advance of ASM Model Start to support participant readiness. And you can begin incorporating workflows for quality measures, IAs, et cetera, now or as soon as possible to be prepared for Model Start in 2027. Another question we received is, are quality measures only captured for Medicare patients or all insurances as MIPS does? So most quality measures in ASM are all payer, so they're captured across all patients, not just Medicare, which is similar to MIPS quality measures. The claims-based measures, however, are only for Medicare patients, and CMS calculates them on behalf of the participant. The all-payer approach gives a more complete view of clinicians' performance and supports more reliable measurement rather than limiting it to only Medicare beneficiaries. And I will stop there and pass it back to Ben for other questions.
Thanks, Mitchell. I'm just looking through Coleman. Looks like there's a couple questions about scoring and maybe some effects on payment. So I'll turn over to you.
Yes, let me make sure I'm not talking on mute. One question is around asking us if there are any adjustments for non-patient facing physicians. And as noted, we have an adjustment for small or solo providers. And we also have an adjustment called the complex patient scoring adjustment, which recognizes that there's a diverse portfolio of patients that providers face and weights and will appropriately weight for ASM participants who provide care for dual eligible enrollees or patients with HCC risk scores above the median. And so those are the two current scoring adjustments, and we don't currently have a scoring adjustment for non-patient facing physicians. The next group of questions, there's a couple questions on what score is considered a good score, what's the minimum score needed, or like what score will determine a positive and or negative payment adjustment. This is because our scoring, our payment methodology is a little bit different than how MIPS does it, right? You all have noticed that MIPS has a performance threshold that if you score above that threshold, you'll receive a positive adjustment and below a negative. Our payment adjustment methodology is based off of how those in a cohort, so the low back pain or the heart failure cohort, compare to each other. So depending on how you score relative to your peers will determine what payment adjustment you receive and whether that payment adjustment is positive, negative, or neutral. So it's hard for us to tell you what score is a good score, other than if you perform well on those quality metrics relative to your peers, you'll receive a better performance threshold. A better payment adjustment. Apologies for that. Ben, I think that's it for me.
Great. And I'll just add another point on Coleman's last point is around knowing what is a good score on a quality measure. We are working to identify different data that can be shared in advance, as well as historical information that may help participants calibrate their performance, particularly in the first performance year. And then I think we'll have more information to share in the second performance year and so on. I did get I think a couple of questions also about suggestions on how we capture TIN and organizational information on the participant list on data.cms.gov, including if we can align it to how TIN appears on the eligibility file. We appreciate that recommendation. We'll certainly look into that if we can update that for the final list. And then I think there's also a couple continued questions about the impact of having some providers in a practice participating in ASM and then others being required to report MIPS, and whether or not, again, ASM participant data can be used in MIPS submissions. We definitely recommend looking, I think the general policy is like, as long as for whatever section of your practice is MIPS eligible in terms of what you can report, that your data submission adheres to the MIPS reporting requirements. That is okay. We also recommend, if you have specific questions about how this might affect MIPS submissions, we also recommend contacting the CCSQ, or the Quality Payment Program helpline as well. Great. Just looking else. Just seeing Aria, I think there might have been a few questions, or at least one question I see.
Yes, one more question for me, at least for now. And the question was, will we get notified if we come off the list? So we do anticipate that the process for releasing each performance year's participant list will be the same as for the preliminary participant list, where we emailed the selected participants and also posted the participant list on data.cms.gov. So not a direct notification if you're taken off the list. You would not receive the email, and you would not see your name and information on the participant list. There is a column for each performance year. Right now, performance years 2028 through 2031 say null, and those will be updated as we move through the performance years. Thanks, Ben.
Thanks, Aria. We're approaching the end of our time, so just want to see if there were any last questions that our team wanted to come off mute. Maybe if we had one or two questions at the most.
Hi, Ben. I had one question that I think keeps coming up around where people can learn more about the quality measures. And right now, the best places in a succinct format would be the ASM website, which has materials like the webcast recording and webcast slides that details the measures that are required for each cohort, but also more detailed information is available in the calendar year 2026 physician fee schedule. So please reference those materials for details about the quality measures and the specific requirements. Thanks.
Excellent. Thanks, Mitchell. All right. I think at this point, I think we're going to transition to closing, but really just want to express our gratitude for all the questions that you're sharing. This is really helpful to understand what resources, technical assistance like activities or that we can provide to help make ASM's requirements clearer to its participants as well. So I think we can head to our closing. So we're going to share a number of links to key resources that are being shown on this slide within the chat. If we did not get a chance to answer your question, I think we got through a lot of them, but I know there were a couple still outstanding. Please email us at ambulatory specialty model at cms.hhs.gov. Again, this model team, many of the folks that came off mute and talked to you all today are the people reading your responses or questions and responding to them. You'll also notice that there's going to be a post-event survey that pops up at the end of the call. So please fill out that survey and provide us with your feedback about this event. And we just want to express our appreciation for joining today's office hours, and we hope that you enjoy the rest of your day. So thanks again and take care.